Institute in Phoenix, Arizona. Thank you.
Thank you, Chitra. Can you hear me okay? All right. Excellent. It's really a pleasure for me to be here this morning and talk about this very important topic of neuropathic pain and paresthesias. I think I'm supposed to tell you right off the bat if I'm going to be speaking about any medications that we might be using off-label for this problem. And I can tell you that essentially everything from a medication perspective that I'm going to be speaking about is off-label. In other words, does not have a direct indication. There's very few that have very specific indications, such as, for example, post-herpetic neuralgia or for trigeminal neuralgia. But most of them are off-label, and so I should mention that right up front. Neuropathic pain is an extremely important problem, and again, preaching to the choir is the theme of the morning, I think. It affects anywhere from 3.5 to 4 million Americans. The Joint Commission on Accreditation of Healthcare Organizations has mandated pain as essentially the fifth vital sign. And as you may know, currently we're in the decade of pain control and research, which was implemented by Congress in 2001. So it's getting more attention, and it certainly is an extremely important problem in neurologic disease and illness. Definition of neuropathic pain as defined by the International Association for the Study of Pain is pain initiated or caused by a primary lesion or dysfunction in the nervous system. This is in contrast to nociceptive pain, which is evoked by noxious stimuli, damage to normal tissues, and thus that presents itself or represents itself as a protective mechanism, in contrast to neuropathic pain, which does not. Now, normally in CNS function, you have a balance between excitation and inhibition within the neural elements of the central nervous system. Excitation being at least in part mediated through compounds such as glutamate and aspartate, the inhibition via GABA. And so there's a gentle balance or homeostatic balance between these two arms of the scale. The problem is in neuropathic pain syndromes, there is typically a imbalance, a increase in the amount of excitation and a decrease in the inhibition within the neural axis. Now, nerve injury certainly does lead to changes, both in the periphery and in the central nervous system. So you have nerve changes as far as the initial neural injury, and that promotes changes peripherally and centrally, and these both lead to development of the syndrome of neuropathic pain. And what you have is a sensitization phenomenon. You've got, again, tissue damage with its concomitant inflammation, with excitation of sympathetic terminals, all developing and leading to a sort of sensitizing soup. And this soup consists of the various neuropeptides, molecules, neurotransmitters, all together, creating a milieu for the development of neuropathic pain. And there also leads us to opportunities to intervene, which we'll talk about later. Now, in talking about neural fibers themselves, nerves, nerve fibers, and types of nerve fibers, I bring your attention to the fact that essentially three of the listing and classification of nerve fibers, essentially three are the main culprits in the development of neuropathic pain. As far as protective nociceptive pain, in addition to neuropathic pain, certainly you have the development of more activity in C fibers and in A delta fibers. And then most especially in neuropathic syndromes, you got activity in the so-called A beta fibers, which we'll talk a little more about later. So we're going to talk a little bit about mechanisms. Yes, we are going to molecules, cells, and so if we can hold on, we'll get through a lot of this information. But the mechanism and pathophysiology from a cellular level, anyway, that involves neuropathic pain very much has to do with increasing intracellular calcium within a cell, which sets off a cascade of events within the cell, activation of certain genes, activation of certain enzymes, phospholipase, protein kinases. All of these produce outcomes that relate to and directly increase the amount of neuropathic pain and the development of neuropathic pain through various receptors, through increased presynaptic activity, through direct cellular changes from gene control mechanisms. And so all of these contribute to this very important problem. Calcium channels, which I'll be mentioning again and again, so-called voltage-gated calcium channels are depicted here in this cartoon. But again, this offers an opportunity for us to intervene with certain medications, which we'll get into in a minute, as far as possible treatment paradigms for neuropathic pain. Calcium channels are not the only channels out there that are important in this phenomenon. Certainly the sodium channels are extremely important. There's a beautiful review by Waxman in Neurology a couple of years ago, which really called my attention to and heightened my awareness that we were learning more and more about the channelopathies. Right now we know that there's at least 9 different genes that encode for distinct voltage-gated sodium channels. And we know that the selective expression of these different genes provide for the different ensembles of sodium channels that are out there. And these different ensembles give different functional properties to the different neurons. You have different types of sodium channelopathies, and those can be genetic in nature or acquired in nature. We know that mutation of genes that occur will produce abnormal sodium channels that fail to function or function abnormally. And acquired channelopathies are certainly seen in peripheral and central nerve injury. So sodium channels certainly have to do with paresthesias and neuropathic pain. They at least arise in part from sodium channel disruption and abnormal functioning within the axons and the dorsal root ganglions, which is where the cell bodies of axons in the periphery live. From an electrophysiologic perspective, it's been shown that changes in sodium channels cause neural excitability through mechanisms such as slow depolarization, and we see this in models such as chronic constriction models of nerve injury. So the molecular identification and characterization of various sodium channels really has shown us that it's the turning off of certain genes and the turning on of others that provide the milieu and the abnormal nature of these sodium channels. But again, they offer an area where we can intervene with certain medications, which again we'll talk about later, as far as a possible treatment paradigm. So looking at these problems in context throughout the nervous system as a whole, both in the peripheral nervous system as well as in the spinal cord and brain. We've got sodium channel problems mainly directed in the peripheral nervous system, and we have a list of possible medications, mainly the anticonvulsants, to direct care and direct possible intervention at sodium channel problems. We've got neurotransmitter problems within the brain and within the spinal cord. Most certainly also we have calcium channel issues and a glutamate receptor problem, again, that we can direct different medication profiles toward. So in the periphery, we have sensitization of peripheral neurons. You've got the collateral sprouting of the A-beta fibers that we'll talk about in a minute. And you've got increased activity of damaged axons and their sprouts. This sets up the milieu in the periphery for the development of neuropathic pain and dysesthesias. Centrally, you've got most certainly central cascade and sensitization, a reorganization of synaptic activity, and the so-called disinhibition or the reduction of inhibitory fibers and inhibitory pathways within the central nervous system. Now, as far as definitions, let's define for a minute hyperalgesia, because you're going to see these different words in text. You're going to hear them being used, and so I think I want you to have a clear definition as far as what we're speaking of when we say hyperalgesia. And what that is an increased response to a normally painful stimulus. But we see this, for example, normally, if there's an area of damage to the skin or subcutaneous tissues or muscle tissues, if there's area of damage, scar formation, that becomes hyperalgesic. It becomes hypersensitive, and this is mainly mediated through those certain fiber types that I elucidated and showed you on the table before, the C fiber mediated. There's certainly an inflammatory component to hyperalgesia. This certainly can be seen normally in areas where the tissue has been damaged and then exposed to a sharp stimulus or heat stimulus. And so what you have in hyperalgesia is certainly increased nociceptive drive that leads to central sensitization. So in the periphery to the dorsal horn of the spinal cord is depicted here, on up through the spinal cord, up into the brain. There is a cascade, an increase in sensitization to this type of painful stimulus. We know that beta fiber input is sufficient to activate the spinal cord pain pathways, and the increase in their activity and the escalation of activity up the central nervous system sets up the system for hyperalgesia. Allodynia, on the other hand, is by definition the interpretation of a non-painful stimulus as being painful. This is a result of qualitative changes in the interpretation of stimulus, and it's certainly mediated both dynamically by the so-called A beta fibers and as well by C fiber mediation. For example, specifically, after a nerve injury, say in the periphery, C fiber terminals within the dorsal or the back part of the spinal cord, they tend to atrophy. But subsequently, the A beta fibers, which are a little deeper within the spinal cord, peripherally sprout. They create new sproutings that tend to take over the areas of C fiber terminal atrophy. And this reduces the inhibitory input, or rather nerve injury reduces the inhibitory input and thus increases the excitability of these dorsal horn neurons. So now we have primary afferent input evoking a much greater response in the dorsal horn of the spinal cord. And these certainly may fire spontaneously. All of these produce, or is believed to produce, the syndrome of Allodynia. This is in contrast to Hyperpathia, which is an exaggerated or prolonged response to a painful stimulus itself, a painful stimulus but with an exaggerated or prolonged response. And certainly anyone who's involved, for example, in tests that do cause pain, and certainly I do fairly commonly EMGs and nerve conduction studies, which is a painful test. And what we see typically in patients is that it's just extremely, or perceived to be extremely painful in those individuals with hyperpathic feeling. It's a normally painful test, but it's felt as intense pain. And it's due to a quantitative change in the interpretation of the stimulus. Mainly, we think about this as disinhibition in the central nervous system, or a dropout typically of interneurons that would normally inhibit or dampen that signal coming into the central nervous system. So disinhibition is the mainstay pathophysiologically in hyperpathia. Now, certainly there are some entities that result from spontaneous stimuli. They spontaneously happen in the peripheral nerve and in the dorsal root ganglion. Mainly sodium channels are at work here, and you've got sprouting of sympathetic nerve terminals within the periphery. And some of these spontaneous entities are called Parathesias, which by definition are burning, tingling feelings, numbness, skin crawling sensations have been described to me, buzzing, itching, pins and needles feeling. All of these occurring spontaneously without apparent stimulus. Now, by definition, a paresthesia is usually not painful, in contrast to a dysesthesia, which is perceived as a painful or very unpleasant feeling. So with these definitions in mind, our goal, again, is to restore the balance between excitation and inhibition in the peripheral and central nervous system. Now, in order to do this, we first have to really recognize neuropathic pain and be able to identify it. Certainly, physicians need to be better at identifying neuropathic pain. Because, pain, yes, which pain? Which is it? Is it an inflammatory or nociceptive type of activation? And certainly inflammatory or nociceptive pain, for example, the pain going along with an arthritis, such as rheumatoid arthritis, that's a direct correlation with the physiology of the pain and the severity of the disease. In contrast, chronic neuropathic pain, such as that results with TM, multiple sclerosis, various spinal cord phenomenon, this is a nervous system, this is the result of nervous system being changed. And the severity of the pain is not at all in concert with the severity of the disease. Instead, it's the degree of neuroplasticity within the central nervous system that relates to the severity of the perceived pain. Now, the symptoms that go along with neuropathic pain, again, can be varied in individuals, but spontaneous feelings such as stabbing and a pins and needles sensation, all of these things go along together. It's, for the most part, an A-beta-dependent mechanoreceptor problem that causes the feelings of allodynia. There's movement or vibration that can produce electric shock type phenomenon down the limbs or up into the trunk and torso. And certainly anything as simple as just palpation can evoke radiating pain. Syndromes that are common examples of neuropathic pain include painful diabetic neuropathy, postoperative neuralgia, trigeminal neuralgia, radiculopathies, cancer-related neuropathic pain, cancer that causes nerve injury and results in neuropathic pain, and of course central pain syndrome as it relates to injury to the spinal cord, brain stem. I just went through these central examples, and certainly peripheral examples also, which we're not going to get into much, will also give patterns of neuropathic pain. So the etiologies, you could have nerve compression, inflammation, ischemia, infections, most notably for our particular topic, demyelination and axonopathies within the central compartments will cause neuropathic pain. You can also have sensory phenomenon in concert with various other phenomena. We already mentioned most of these sensory phenomenon as being ongoing, spontaneous. Hyperalgesia we've talked about. You could also have negative sensory phenomena, such as deficits and numbness in areas. And they can be seen in concert with motor abnormalities, certainly negative motor phenomenon, such as weakness, clumsiness, fatigue, positive motor phenomenon, such as tremor, dyskinesias, dystonias. So how do we assess it? Now, we don't have time in this half an hour to go through all the different pain scales out there, but I think that the take-home message here, no matter what scale it's being used, whether it's a numeric scale, visual analog scale, or the various other assessment tools that are out there, the bottom line is that the modest changes in various pain scales that are out there are associated clinically with meaningful changes in the individual. So I always caution colleagues and people that I work with that really, although various treatment paradigms may not produce the numeric changes in scores that one would hope, but that even just small changes will produce important patient impact in their lives and in their ability to function. And certainly physicians need to be keenly aware of that. It's most important in a pain assessment task is to ask the right questions during the interaction with you and with your physician. Help them ask the right questions, I suggest to you. And looking at onset, location of pain, the time profile, characteristics and quality of the pain, severity, the unpleasantness, what factors exacerbate or improve the pain, psychological factors, is anxiety a part of it, is panic a part of it, aggravating factors, alleviating factors, as we said, and how does it function, how does that pain impact on function and on activities of daily living. In addition, asking about what are the best treatments that the individuals have had in the past, their habits and coping skills related to the pain is very important. We all have to recognize that neuropathic pain is most certainly a biopsychosocial disease, and calling together a team of individuals into your inner circle, so to speak, and a physician calling together a team of individuals to help care for patients with neuropathic pain, including physical therapists, occupational therapists, rec therapists, vocational counselors, psychologists, and psychiatrists, as well as the physician himself, together in a team approach to this very complex problem. Now, as far as treatment, which is really, I know, a keen point for this talk, there is no panacea, that's for sure. There's no one drug that is approved for the general use of neuropathic pain as it relates to central nervous system problems. I submit to you this somewhat busy schematic that talks about a lot of the non-pharmacologic treatments that are out there. For the most part, I can offer you very little in the way of controlled trials proving the efficacy of these various methods of treating neuropathic pain. For the most part, they do no harm, well, except maybe for bloodletting. Too many leeches on anybody doesn't seem to help. But for the most part, these certainly can be tried, in the total treatment paradigm for neuropathic pain. But in deciding what treatment is best, certainly you have to determine the mechanism. Is it really neuropathic pain? First of all, are there other contributing factors to the pain, such as nociceptive pain that results from bony instability, ligamentous instability, inflammatory pain? Spasticity certainly needs to be treated and can incite neuropathic pain. And sometimes treating the spasticity alone will reduce the pain perception. And then specifying your target, trying to target the underlying cause, trying to target the pain characteristics themselves and the putative pathophysiologic mechanisms. So getting back to this slide, what are our target areas? We can certainly target sodium channels. We could target central brain neurotransmitter target areas. We can target calcium channels, and we could target glutamate receptor targets. And that is exactly what we're doing with these various classes of medications that are currently being used, albeit essentially off-label for the most of them, which include the antidepressants, including the tricyclic antidepressants and the selective serotonin reuptake inhibitors, the anticonvulsants, antiarrhythmics, some topical formations, which we'll talk about, and others, as many as we can get through in our given allotted time. Let's look first at the tricyclic antidepressants. Their molecular structure, as their name implies, is a three-ringed type structure. The various old literature supports their use in post-herpetic neuralgia, but we use them routinely in neuropathic pain syndromes. The problem with them are their side effect profiles for the most part. For example, amitriptyline, very sedating. You can see weight gain. They all have some degree of anticholinergic side effects, okay, some less than others. And so their side effect profiles will help us use the correct agent. If we're going to go with respect to the tricyclics, going to use their treatment paradigm as a treatment paradigm, we're going to utilize their side effect profiles to help choose which is the best for a given patient. Certainly we have to use them with caution in older individuals due to their anticholinergic side effects. If we look to the serotonin system medications, the selective serotonin reuptake inhibitors, these also have been used in painful diabetic neuropathy. Certainly, there's several of them out there that have been looked at in controlled trials. Some impact both the serotonin system as well as the norepinephrine system, but centrally acting agents in the central serotonin and norepinephrine systems are certainly one method of getting at neuropathic pain. We can utilize NMDA receptors, but we're really in our infancy in looking at and really having optimal compounds to use in this area. How about some topical medications? We can talk a little bit about the use, for example, of capsaicin, which is a pepper derivative. Unfortunately, capsaicin has a couple of problems associated with it. Certainly the first takes about 6 weeks to really get effect, and the first 2 weeks can be particularly painful, and burning associated with the initial application for those first several weeks can be quite distressing and can really turn patients away from its use. Another topical agent called emla cream essentially helps some people, especially with allodynia, in blocking the input from the peripheral sites. There's other medications, clonidine gel, lidocaine patch, and also you have to call attention to the fact that lidocaine is actually a very potent inhibitor of central pain. This was shown by Nadine et al., published in Neurology, but that was IV and is really not practical for use on a day-to-day setting, but does show very, very exquisite dampening of central pain phenomenon. How about the anticonvulsants? This is the area where I think we've grown most steadily in our understanding and in their use patterns. We've got first generation or the older anticonvulsants such as carbamazepine or Tegretol. Phenytoin is very old. In addition, we have then the newer second generation anticonvulsants, gabapentin, lamotrigine, and some others, which we'll talk a couple minutes on. First, phenytoin, probably the oldest. The mechanism of action is directly related to those sodium channels I alluded to before, which really slow their rate of discharge and limit their repetitive firing, which is the underlying pathologic mechanism in the development of neuropathic pain from the sodium channels. Phenytoin may also inhibit somatostatin release, but there's really conflicting studies on its efficacy, and I don't think that we'll see much more about it in relation to treating neuropathic pain. Carbamazepine, on the other hand, has certainly been approved in trigeminal neuralgia. This goes by the brand name or one brand name of Tegretol. Again, it acts at the sodium channel level, limiting the repetitive firing. It may also inhibit the release of somatostatin. It has some calcium channel antagonistic effects, so here we're hitting two different types of channels. And you could see by its structure that it is also very, very similar to the tricyclic antidepressants in that it's a three-ring structure, and it certainly has a similar efficacy profile as the tricyclic antidepressants. The problem with it is that we do see on occasion something called aplastic anemia, which is a depression of your bone marrow's ability to produce cells, which is something that needs to be closely monitored with blood work on its with its use. And generally speaking, a median dose in various studies have shown that around 600 milligrams a day will at least be a starting point. A close cousin, oxcarbazepine, also slows recovery rate of the voltage-activated sodium channels and limited its repetitive firing. modulates both the N and P-type calcium channels, so here we're hitting both sodium and calcium channels again, and also may reduce glutaminergic transmission. It's been approved in trigeminal neuralgia, but again, we use it off-label for neuropathic pain in general. But again, we have the problem with potential for aplastic anemia and agranulocytosis, both a bone marrow suppressive phenomenon. Now, how about gabapentin, brand name Neurontin? This is a second-generation anticonvulsant. It's probably the medication I've had my best success with as far as treating patients with neuropathic pain. Increases GABA, which is a neurotransmitter, an inhibitory neurotransmitter within the brain. It possibly enhances the rate of synthesis from glutamate. It binds to voltage-dependent calcium channels, so we're hitting channelopathy also. Inhibits sodium channel currents by a mechanism that's distinct from the first-generation anticonvulsants. And it inhibits branched-chain amino acid transferase, so possibly reducing glutamate concentration centrally. These are the areas that it imposes its benefits, and so we're hitting several possible mechanistic targets with gabapentin. It's been studied in a number of different diagnostic categories, including painful diabetic neuropathy and post-herpetic neuralgia, and generally in neuropathic pain, and has seen positive effects in all categories. In a multi-center randomized double-blind study, it's been shown that doses up to 3,600 milligrams a day, at bare minimum 1,800 to 3,600 milligrams a day, has been shown to have good efficacy in controlling neuropathic pain. Most common side effects, certainly dizziness, somnolence, and ataxia are probably the three I see the most. As far as topiramate hydrochloride, this is also a channel blocker, blocking sodium channels, also inhibits a non-NMDA type glutamate receptor and enhances GABA receptor actions. And so certainly this is another possible means of interfacing with neuropathic pain, which needs to be looked at more closely in the future. Topiramate problem with it is that in one study, some 30% of individuals on the medication exited the study due to concentration, reduction in concentration, language problems, and psychomotor slowing. So the side effect profile is certainly important in this particular medication's use. How about lamotrigine? Lamotrigine also acts at the sodium channel level. It inhibits neurotransmitter release, especially glutamate release, and in 2 studies it has shown to be effective in helping central pain, such as caused by stroke and spinal cord lesions, in the doses of 200 to 400 milligrams a day. In one study, it's been shown with efficacy in post-diabetic neuropathy and painful diabetic neuropathy. The significant concerns with lamotrigine include rash, and most specifically Stevens-Johnson syndrome. So a necrotizing rash is certainly something that we need to look out for. At the first signs of rash, discontinuation of lamotrigine is critical. So here we have a summary then of what are the possible neuromodulators, the anticonvulsants and the antihyperalgesics, which are really at this point considered neuromodulators. We can hit calcium channels, we can hit sodium channels, we can try to hit GABA receptors and GABA metabolism, glutamate receptors and glutamate metabolism. These are the main areas and mechanisms of action of these various medications. And our conclusions at this point, among others, but most notably, is that neuropathic pain is certainly something that can be difficult to diagnose, is most definitely misdiagnosed in many instances, and very likely underreported and underrepresented. Treating only the inflammatory or nociceptive components of chronic pain in general will be ineffective for neuropathic components. Treating the triad of pain and the concomitant mood disorders, as well as functional impairments such as sleep disorders, together must be addressed. Modest improvements in pain scores on pain assessment scales can be very important and have a larger impact on the patient life and ability to participate in rehabilitation programs, which is, of course, the ultimate goal of treatment. No one agent is approved for the overall use of neuropathic pain. We have to choose medications based on careful consideration and the intended effect as far as the pathophysiologic schema I've presented to you. And at times, certainly rational polypharmacy, more than one drug, switching from one drug to another may be necessary to get at these major target symptoms. Other options which we really don't have time to discuss now, and certainly options for the future, are with the availability of intrathecal pump systems, such as baclofen is being delivered right now through an intrathecal pump system. We can move toward the delivery of these various medications directly into the cerebrospinal fluid intrathecally with these various pump systems. Also out there are the surgical options, which again we can't get into right now, but knowing that they exist and that they are a last defense sort of option, nerve lesioning, actual transection of spinal nerves, transection of the cord, believe it or not, has been used to try to control neuropathic pain. And then, of course, the use of deep brain stimulators and spinal cord stimulators are also out there as possible options, but as a last resort type activity. I want to thank you for your attention. I think what I'll do is I'll hang out in the DevEx area here and for any questions. I think we're already into break time, and I apologize for going over. Thank you for your attention.